Hello, everyone. My name is Subarna, and I'm so happy to welcome you all to the fourth annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department in partnership with the Washtenaw County Medical Society. This virtual series is aimed towards healthcare providers with the goal of raising awareness and opening discussions surrounding cannabis use for medical practices. Our speakers come from a wide range of backgrounds and are experts in their respective fields related to medical cannabis. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. I'm so pleased to introduce today's speaker, Dr. John Hopper. Dr. Hopper graduated from the Wayne State University School of Medicine and completed residency training in combined internal medicine and pediatrics at the University of North Carolina, where he served as co-chief resident in pediatrics. Dr. Hopper was appointed to the faculty at Wayne State University School of Medicine in 1994, where he served as Associate Program Director for the Meds-Peds Residency and Medical Director of the Department of Psychiatry's Research Division on Substance Abuse. From 2005 to 2008, he was the Chief Medical Officer at Brighton Hospital, the second oldest addiction treatment hospital in the United States. From 2008 to 2015, Dr. Hopper directed the Internal Medicine Residency Program at St. Joseph Mercy Hospital in Ann Arbor, Michigan, where he continues to serve as a clinical faculty member in addiction medicine and internal medicine. From 2015 to 2020, Dr. Hopper was a CLER site visitor for the Accreditation Council on Graduate Medical Education. His current clinical efforts are with the Trinity IHA Medical Group, where he also serves as Medical Director of Patient Experience. Thank you so much again, Dr. Hopper, for joining us today, and I'll let you take it away.
All right, thanks very much. I'm going to share my screen. All right, I'm really grateful to everyone for being here today. I have a lot of gratitude for you all and your interest in this topic. I think cannabis use, medical cannabis, is quite controversial, but fortunately, I think everyone can be on the same page as me in that adolescent cannabis use is a problem, and whether it's there really is no medical role for cannabis in adolescence, and the impact of societal's view on cannabis use has a huge impact on adolescents. So the topics today, let's see. We're really going to talk about what are the trends, and there are some big updates from last year. We'll look at what we know about consequences of adolescent cannabis use, and then specifically screening for and intervening for cannabis use in adolescence. And I think this quote is one that you have definitely heard me used before. In any adolescent talk, I like to point out that adolescence is a really challenging period of human development. I think David Foster Wallace in one sentence here captures it better than anyone. And he certainly understood the difficulties of adolescence, and as someone who was challenged with his own mental health issues and died by suicide, we're going to come back to this again here. So our current state of cannabis in Michigan is one of allure. I know as a county resident in Washtenaw, I've become used to the fact now that if I see a nice new building going up, it's probably going to be a cannabis shop, or if a flashy billboard comes up, it's probably related to cannabis. I decided not to use any specific ads for any cannabis in Washtenaw here, so this is a generic billboard, and that building there you may recognize is actually a very nice restaurant in Novi Shiro. If you like sushi, I would recommend it. But it's everywhere, and everybody who can read, so down to as young as third graders, sees these billboards coming up and sees the new attractive sites and dispensaries and people waving, grand opening with billboards directing you to the parking lot. So I think the bottom line here, and this is what I really hope people will take away from this today, is that right now our society is not really applying a smart approach to marijuana. And there is actually an organization dedicated to that, SAM. And I think there's probably three things that I should highlight about SAM and how we should be thinking about cannabis from a policy standpoint. So if you look at the bottom, preventing another big tobacco. This should be one of our goals as a society, is not to allow marijuana to become the next big tobacco, because it is an addictive substance. It does have health consequences, and the consequences are particularly severe for the younger people who use it. After the age of 25, the consequences are far less harmful. So that's one thing. I think the approach that we should take as a society really is spelled out right there: health first approach. Anything should be based on, whether it's science or policy, we want to look at what's the health impact from both mental health, public health standpoint. And then finally, if you look under mission and vision, you see the words commercialization and normalization. That's the problem with the approach that we have to cannabis right now, is that the commercialization allows for normalization, which makes people think that cannabis has less harm than it might, particularly for developing brains. So I definitely encourage you to take a look at SAM if you're thinking about what can you do from a policy standpoint. So let's look at the current trends here, and we have some really big updates in the last year. This is the first set of post-pandemic data we have in terms of adolescent use. And I think this is a particularly interesting set of data here with Monitoring the Future, which of course is based out of University of Michigan, national survey of 8th, 10th, and 12th graders. And you can see substantial decreases in lifetime use of cannabis among 8th, 10th, and 12th graders in this post-pandemic report. So is this a temporary blip, or is this a permanent trend? Probably the former, but time will tell. So this is lifetime prevalence. And you can see right now for 12th graders, as of the 2021 data, they're reporting lifetime use of cannabis of around 35%. So a little bit lower than it's been. You can see in the fairly recent past, low 40s. So substantial drop. Big drop among 10th graders, and also a substantial drop among 8th graders. I think the most concerning statistic when you look at Monitoring the Future is always the prevalence of daily use. So among 8th, 10th, and 12th graders, those who report daily use. And in the survey, data is actually, I think, 4 times a week comes out to daily use, but nonetheless, these are the regular users, the people who are most likely to develop any kind of problems or consequences. So for 8th graders, it's less than 1%, but it's still a substantial percentage. For 10th graders, somewhere around 3%. And then 12th graders, more than 5% of 12th graders report daily use. There's no specific National Survey on Drug Use and Health is another survey, and this looks at the United States population age 12 and older. This is a slide I showed last year, and it's just to show that although marijuana use is still quite prevalent, it's far behind alcohol and tobacco, are widely legal drugs. But this emphasizes a really important concept as well from the 2019 National Survey on Drug Use and Health. Marijuana, new initiation of marijuana in 2019, 3.5 million new users aged 12 and older. So more new users of marijuana than there were new users of cigarettes. Now, this doesn't show nicotine products and vaping products, which were quite high, but you can see marijuana use is second only to alcohol in terms of new initiation in the 2019 data. Now, the 2020 data for initiation shows a rise in over 2019. So 3.5 million, I'm sorry, there is this drop here in the 2020 data from what we just looked at. So down to 2.5 million new users of marijuana in the United States, 12 and older. So just to go back one more time, 3.5 million new users in 2019, 2020, there's a drop, 2.5 million. So this parallels what we're seeing in monitoring the future. So that is somewhat encouraging. How much this is related to the pandemic and how much this will change, we'll see. And you can see they didn't actually connect the dots here on this new set of data, and that's because they were using a new methodology. So time will tell if this is a permanent trend or just a blip. As I mentioned, nicotine vaping, very high. How does that relate to cannabis? Well, if you can vape nicotine, it gives you a mechanism for vaping cannabis. And we know that a high percentage of e-cigarette users will also vape cannabis. This is old data, but it holds true. A large percentage of kids who are using e-cigarettes will also vape cannabis. So as you can see, trends, perhaps some encouraging signs. So let's talk about consequences. I think it's really important when you're looking at anything, there's use, and then there's a spectrum of use that can include use disorders, mild, moderate, severe. We would consider, sort of a severe substance use disorder is what, the general terminology would be addiction. So people who continue to use despite harm and can't stop using. And for adolescence is a time of experimentation. So whether it's marijuana, alcohol, tobacco, the majority of adolescents who start using substances don't go on to develop a use disorder. And one of our goals really as clinicians is to be able to identify those at risk of progression and then intervene for those who are starting to develop disorders. This is, of course, the DSM-5 criteria for what's a use disorder, mild, moderate, severe. It only takes 2 to 3 of these on a given substance to meet the criteria for a use disorder. So we consider it a severe use when there's impairment of control and there are specific consequences that are occurring. And so again, addiction would be considered a moderate to severe disorder. And this is a chronic relapsing disease. And it's characterized by things like compulsive drug seeking, use despite harm, and craving, which is a new addition to the DSM-5. And this is an article that I think is worth reading if you aren't familiar with the neurobiology of the brain disease of addiction. This is a great introduction to it. The last sentence is included in the slide here because it is a really important sentence when you think about drug use. And I'm going to just read it because of its importance. If early voluntary drug use goes undetected and unchecked, the resulting changes in the brain can ultimately erode a person's ability to control the impulse to take addictive drugs. So this really is the definition here: continued use despite harm. People ultimately are being driven purely by behavior and not by desire. It's really a reflex use that leads to addiction. And we understand a lot more about the interplay between reward, emotion, and then continued use in terms of sensitization than we did in the past. Having said that, cannabis is by far the most complex of the psychopharmaceuticals, the brain-altering chemicals, and likewise the cannabinoid physiology of the brain. We understand probably much less than we do for nicotine, heroin, alcohol, stimulants. And there's a lot of reasons for that. The Schedule 1 restrictions on marijuana having no therapeutic benefit, it makes it much harder to research from a research standpoint. So having directed a research division, it was always a lot more challenging to do research with Schedule 1 drugs. And as a result, we're really far behind in where we need to be in terms of understanding the neurobiology specifically around cannabis, and in particular as it relates to cannabis and the developing brain. And why is that important? Well, of course, the development of a substance use disorder, i.e. addiction, is an interplay between the genetics, the exposure, and then the interplay in terms of brain mechanisms, particularly as it relates to when during the brain development is the exposure occurring. So we know from virtually every psychoactive substance that we see, whether it's stimulants, nicotine, opioids, alcohol, the earlier that the brain is exposed, the greater the neurological consequences. And for those who develop use disorder, the more severe and persistent the disorder. So that's the reason why tobacco companies want adolescents to start smoking. It's the reason why alcohol is such a problem before the age really of 25, but I'll settle for 21. So until the brain is fully myelinated, somewhere around 25, you're going to have problems if you expose developing brains to drugs that have the potential for misuse. And when you think about brain development, of course, the earliest development is in pre-toddler, the cerebellum. Motivation and rewards occurs in early childhood, but emotional development does begin in the pre-teen years and is still developing into young adulthood. So when we talk about exposing brains at an early age, and you're thinking about cannabis, one place that is really important is the amygdala, which of course is not only related to emotion, but also fear and anxiety. And then finally, the prefrontal cortex, which really, as I've mentioned, isn't fully developed until 25. So these areas of emotional and judgment development are impacted by drug exposure. So if we're, again, I think it's pretty clear as a society, our goal should be to try to protect developing brains from drugs that might alter the trajectory of development. So I think this quote here from Renard's paper in Frontiers in Neurosciences is a good one. That emerging evidence from human and animal studies shows early onset marijuana use has long-lasting consequences on cognition. And in humans, this is associated with a twofold increase in development of psychotic disorder. Whether it's twofold or not, we're not sure, but it certainly is an increase. And also, when we talk about consequences on cognition, think about that from the standpoint of the definition of cognition from Jonathan Cohen here. Cognition is the ability to orchestrate thought and action in accordance with internal goals. So impairment in cognition ultimately leads to people having thoughts and actions that aren't really necessarily aligned with where they want to be and what they want to do. So this has a huge impact on adolescents. And of course, when we're thinking about the frontal cortex and the decision-making, Sapolsky says it best here, the frontal cortex makes you do the harder thing when it's the right thing to do. So when it comes to marijuana use disorders, so for regular users, and remember that was the 12th grade population in the 5 to 6% range, up to 30% of them may develop some kind of use disorder, so DSM type of criteria. And the risk of disorder is much greater if you start before age 18. We don't have better data, but probably the younger you start, the higher the risk. And we know that ultimately about 9% are going to develop dependence. So that is, say, better than if you look at nicotine, where the development of dependence is much higher, but up to 17% for those who start using in their teens. And the withdrawal symptom can last for a couple of weeks, and depending on the age and the duration of use, it can be quite severe and distressing. A lot of effect on appetite. Nausea can occur both as part of the intoxication, but as well as the withdrawal. And mood can be very severely disrupted by marijuana withdrawal. So when we look at the environment and we think about, friend or foe, I put this is good old Michigan fudge. This is real fudge, unlike other places in Ann Arbor where you can go and there'll be a big sign that says fudge, but it's actually marijuana. And so this is part of our problem with sort of the commercialization and marketing, is that when we use terms like fudge and cookies and gummies and edibles to describe drugs that have an impact on developing brains, it really sort of lessens our concern about its exposure and gets us not really thinking about where we need to be placed in terms of a smart approach to cannabis. And why again, the marijuana, it really makes a difference in terms of what's the THC content. That is the psychoactive component, the thing that leads to the high. The thing that's really striking about this graph here, if you look at 2008 through 2019, THC content hasn't changed all that much. And if we look at it as a ratio to cannabidiol, that may have an impact as well, and that may even have gone down a little bit. So cannabidiol levels are going up a little bit. But nonetheless, if you look at the pre-2008 data, THC content back in the 80s and 90s, when marijuana was actually at its peak use in 1981, THC content was less than 3% at that time. So we have a much, much more potent marijuana. So even in terms of our longitudinal studies for people that have been using marijuana for a long time, we don't really have longitudinal data on this high potency THC in adolescence. So when it comes to consequences, very hard to know. And this is a critically important concept to understand in the realm of adolescent substance use here, is that there's an inverse correlation between use and perceived risk. So now there is a little bit of encouragement in the most recent set of data, 2021, for Monitoring the Future. You can see that among 12th graders, 10th graders, and 8th graders, there's a little uptick nationally in perceived risk. And that is the year where we saw a decrease in, fairly substantial decreases in use. So we'll see where this goes in the long run. One thing that I'm not aware of anybody having looked at, but I think would be really interesting to look at, is how risk varies in states with and without legalization. I imagine people are working on that. I just haven't seen any published data on it. It would certainly be, concerning, of course, if risk is not going up in states. The perceived risk is going down, for example, in states where there's legalization. So this article, although more than 8 years old at this point, still remains one of the best references on the adverse health effects of marijuana use. And the table that accompanies it shows where we have evidence that's fairly strong in terms of short-term use and heavy use. Emerging data shows that when you look at short-term use and impaired motor coordination, traffic fatalities are certainly going up in states where there is greater use of marijuana. There's more traffic fatalities associated in states that have legal marijuana now than there were prior to the legalization of marijuana. This has a really big impact on adolescents. One of our big successes in the United States is having the alcohol 21 laws. But nonetheless, when teens get access to alcohol, teens in the United States have a lot of access to cars as well. And so alcohol and cars are a really bad combination. We know it's a bad combination for cannabis and cars and teens. And we'll see. The national data definitely shows an increase in traffic fatalities, but I'm not sure if there's one specific for adolescents at this point. And then again, short-term use in high doses can result in paranoia and psychosis. And then long-term heavy use Again, about 9% of users overall will develop addiction. There is certainly altered brain development, and this is associated with particularly early use. Poor educational outcome, increased likelihood of dropping out of school, cognitive impairment, and then some respiratory symptoms. So, unfortunately, if you talk to adolescents, they're actually aware of a lot of these. It surprises me how aware they are that there might be some impact on cognitive impairment, but you're at an age where, as the title of the talk is, it's not a problem. That might affect other people. It's probably not going to be a problem for me. I'm not worried about it. So genetics does play an emerging role here, and we certainly see there's probably a genetic component to risk of addiction. Likewise, the risk of psychosis probably varies with certain genetic variations. And we know that marijuana and psychiatric disorder is associated with not only psychosis, but anxiety and depression, and that potency matters, and that if there is use of more than one substance, we probably have even greater risk. Now, this article has nothing to do with cannabis, but everything to do with the frightening impacts of exposing adolescent brains to a psychoactive drug. So anybody who knows me knows that this is the article that has me most concerned for our society. If you expose developing brains to nicotine, there are profound impacts that happen on neurological development. And in fact, it makes the brain more susceptible to stimulant misuse. And we are starting to see greater rises in stimulant misuse in the United States nationally. So both rising methamphetamine use, as well as increasing cocaine use, as well as misuse of prescription stimulants. And one of the reasons I suspect that we're seeing these rising rates is that we've had much more adolescent brain exposure to nicotine in the last 10 years. So this article, very dense, but extremely informative. We don't have a paper like this for cannabis for a lot of reasons. It's much more complicated to study. Cannabis varies a lot in terms of its potency, its concentration, the delivery methods vary. We just don't have longitudinal data. We don't have the animal models for it. But what we do know is concerning. Even if it's only half as bad as nicotine, it's still way too risky for our society to be allowing adolescents to get exposure. So, as I mentioned, the importance here with adolescents is that we're screening for use, and then we're monitoring use. Most adolescents aren't going to develop use disorders, but the first step is to identify who's at risk, and the CRAFFT is the gold standard. So this is for clinicians. If you're not using this as your screening in practice, I'm not sure if there's a better tool, I guess let me know. But this is very, very well developed for adolescent screening. It can be done as an interview. It can be done with pen and paper. It can be done electronically. Adolescents apparently respond very well to the electronic version and probably give you the best data. Now, prior to these questions, you would ask a few questions about tobacco or alcohol use. And even if the adolescent has no personal use of alcohol or tobacco, the C question is still recommended for everybody, because that's, have you ever ridden in a car driven by somebody who is high or using? So, and this could be the parents. And if that's the case, that can be very concerning, and there's definitely a need for intervention. The other questions are specific to the adolescent who's using some type of psychoactive drug. This could include tobacco or alcohol, cannabis, or other drugs. And the nice thing, the thing I like about the CRAFFT is it really does go beyond screening, as it gives you some idea of context and assessment. It really helps you have a meaningful conversation. So this is why I think CRAFFT is a particularly helpful tool for clinicians if you're going to talk to your patients about cannabis use. And this is the full CRAFFT, and you can see asking the past 12 months about drinking any alcohol, smoking any marijuana or hashish, using anything else to get high. If it's no, then you still do the CAR question. And if it's yes, then you go into the full CRAFFT. So a really nice tool. And then in terms of brief intervention, there are numerous brief interventions. This is one that we've been teaching for a long time, my colleague at Wayne State, Dr. Ayers, and myself. And Heather, this is a real patient who wanted help with prescription drug use. She was using opioids and stimulants. She's a non-smoker, occasionally used some alcohol, had some binge use on weekends, and then near daily cannabis use. And this is, the title of the talk here. It's not a problem. Very, very common for adolescents to say that she really only wanted help with the opioids and the stimulants. And on one hand, she did pretty well from an opioid and stimulant standpoint. Unfortunately, the alcohol use progressed, the cannabis use progressed. She really got into a lot of problems. So when finding out about cannabis use, this brief intervention really is to create some cognitive dissonance through the interview process here and asking, so is cannabis causing any problems? Or you could take an even more motivational approach, which would be to say, so it sounds like cannabis isn't causing any problems at all for you, and allow the youth to reflect on that. And if the answer is nope, it's not causing any problems, then the next question would, well, would there be anything good about quitting or stopping your cannabis use? And most of the time people can come up with some superficial answer, but again, if they can't, then they probably really don't have a reason to quit. And I think that's somebody you're going to be monitoring longitudinally. But you can still ask them, let's say you wanted to quit. What would be hard about quitting? And again, you can tailor it to the context. So if you know that they're typically smoking after school or on weekends, with friends. So the next time you were with your friends after school and if you decided you weren't going to smoke, would that be hard? What would be hard about it? It's a really nice way to have a conversation around it and really understand their motivations and drivers for use without passing any judgment. Now, having said that, I think it is really important that the young person, the pre-21-year-old knows that you're not condoning use, and that from a health standpoint, you think it's best if they wait until adulthood to try using recreational cannabis. It needs to be really clear if the parent were to ask the youth, the patient, did Dr. Hopper think it was okay for you to smoke cannabis? That the youth says, no, Dr. Hopper didn't think it's okay. But at the same time, we're able to have a conversation about it in a way that allows longitudinal, open approach to the conversation. Summarizing is critical here. So stating where the person's at, and perhaps you'll leave them with some thoughts. If they see no advantage to quitting, ask them to think about when they're in some of those situations in the future, if there would be anything that would be a benefit of quitting. So when it comes to treatment for adolescent, active substance use disorders, this guide from NIDA, National Institute on Drug Abuse, is probably 20 years old at this point, but the principles haven't changed. And these are the 13 principles here. I think things to highlight are that legal interventions and sanctions may pressure families into getting into treatment, and that's not necessarily a bad thing. So coerced treatment has a benefit. And it actually has a benefit not just for adolescents, from the family. And number 8, families and community are important aspects of treatment. This is one of the biggest challenges in working with adolescents, is that families might be enabling or aggravating use, and they may not feel any obligation to be involved in the treatment planning. There's many, many families that sort of drop the child off, say fix them and send them back. And of course, adolescent use in particular occurs in the context of the family and the community. And it really does take a family approach. So the challenge is that it often means family therapy. And it's hard to find family therapists. It's hard to get families involved in the therapy and find the time where you can get everybody together. So it is a really, really big challenge for working with adolescents who do actually have more severe use disorders. So our biggest benefit in the long run isn't really going to come from prevention. Not to say that treatment isn't important. Now, Michigan has got a lot of money now that's coming in from marijuana taxes. As far as I'm aware, very, very little is going towards prevention or treatment at this point. I believe that the Washtenaw County has been particularly proactive about this, and they are putting a lot of money into equity, which is fantastic. But prevention dollars, just like for the tobacco settlement dollars, are few and far between. My understanding, and I could be wrong about this, I'm sure somebody on the call who knows better than me, but I think more of the tobacco, of the marijuana tax money in the state of Michigan has gone to roads than any other single line item. Not sure how it relates. This, again, a very old, but the most recent document from National Institute on Drug Abuse on preventing drug use, the principles remain the same. Some of the tools and methods will be different from what they were in 2003, but it really does involve schools, communities, and parents as part of the prevention, but really a societal approach. And when it comes to cannabis, we really, I do believe, are going in the wrong direction. We're going in the direction of big tobacco. And even with cannabis, we're seeing consolidation and bigger entities and out-of-state entities that are trying to get in. There have definitely been some benefits to legalization. The price has gone down, and it is now cheaper to get legal cannabis than it is illegal cannabis. So that's certainly a benefit. But the big profits have decreased for the smaller independent dispensaries. And as a result, we're going to see more consolidation, I think, in the industry, leading to, again, bigger marketing, commercialization, and big cannabis. So finally, Iceland is the model for prevention when it comes to tobacco and alcohol, because they, in the 90s, had the highest rates of tobacco and alcohol use of Western Europe. And as a society, they rallied around the idea that this is not good and that developing brains need to be protected, which I think we should all be able to rally around. I think it's not really a bipartisan issue. It's the reason we have, again, the tobacco 21 is still not well implemented nationally, although it is the law in the United States. Likewise, cannabis varies, but there are areas where legalization really has an impact. So what did Iceland do? And you can see the impact here in this graph on the bottom right. You can see the substantial decrease in tobacco and alcohol use that occurred in a decade in Iceland. They now have the lowest rates of adolescent tobacco and alcohol use. And that was done through basically parental education and involvement, getting parents to not allow kids to sit around the house and drink after school in the dark winter hours in Iceland, and getting a wide range of activities that any adolescent should be able to get involved in, whether it's music, sports, art, drama. There's something for everybody. And really reaching out to the most vulnerable and at-risk populations. They put the most of the prevention dollars into that population. So we really need a similar approach here. And I think, I do hope that Washtenaw County can be a leader in this area. So I want to come back to this concept here that, again, cannabis in adolescence it's attractive, and it's a way that we can return to childish oblivion and not face the frightening realities of school or home environment or challenges that are developing. And I want to close with an article here. This is about adults, but I think it really, really relates to the topic here. So it's a fairly recent publication from the Journal of Addiction Medicine on the association of current and remitted cannabis use disorder with health-related quality of life and employment among U.S. adults. So earlier we talked about cannabis having the potential for decreased lifetime achievement, and that's been well known and studied. And in this stratified data across the United States population, they saw that cannabis use disorder, both current and remitted, is adversely associated with quality of life, and that current cannabis use disorder is adversely associated with employment. Now you might wonder, is that related to drug testing? And perhaps, although lots of employers now are no longer testing for cannabis use because they're so desperate to get employees. But the really interesting thing is when that they adjust this for behavioral comorbidities, things like depression, anxiety, the significance was no longer significant. So it really isn't the cannabis use that was associated with poor quality of life or likelihood of employment, but these are markers that people who have poor quality of life and are less likely to be employed are going to use more cannabis. And that's really what I think the concern here is, that cannabis, whether you're an adolescent or adult, is probably a marker for something that's out of balance in life. And our focus really should be bringing balance and better mental health, as the quote from David Foster Wallace would suggest. But really, if we are really focusing on having a meaningful and enriched, mindful quality of life, one where we pay attention to anxiety, depression, and we address that and intervene, we're going to have less cannabis use, whether it's adults or adolescents. So I think that really is ultimately our goal here, is to improve quality of life through improving mental health. And that if we allow the commercialization and marketing of cannabis, it's going to be just another way for people to mask symptoms of unhappiness and out of balance life. So big picture solutions then, again, early childhood education and development. Being able to read well by the 3rd grade is one of the single best predictors of future health outcomes. That just giving brains that advantage of being able to read and develop by the age of around 8, that pre-teen year, that advances brains to the point where if you can read well, you're going to be better off from the standpoint of neurodevelopment and judgment and emotion. Wellness education certainly is not part of our current curriculum anywhere in terms of what the K through 12 education looks like, whether it's diet, activity, exercise, healthy relationships, healthy communication. And then supporting sober environments. So marketing and commercialization, to me, that's the big problem with cannabis here, is that the marketing and commercialization tend to decrease people's perceptions of harms. And we know that taxes do have a big impact on adolescent use of tobacco. So adolescents are less likely to smoke as taxes go up for cigarettes. Now there is a balance here that, if taxes are too high, then people will get into the illegal marijuana market. So I think we're at the right stage here in Michigan in terms of the taxation rate hasn't had an impact. Illegal markets are going down, so that's okay. Zoning, again, the very permissive access to dispensaries. Does that have an impact? We don't know, but certainly alcohol zoning has an impact on use. We know that for adolescents. So something from a policy standpoint that an agency like SAM would be looking at. And then treatment for mental health, early intervention for substance use, making it easier to get treatment than it is to get drugs. something we have not aligned ourselves yet to in the United States. And then certainly I absolutely support the decriminalization, the expungement process that's happening for adults. Legality is not the issue or the concern for adults. Certainly, if you've heard me talk before, I've heard me mention in Portugal, drug use is legal. They don't spend a lot of money trying to intervene. Well, the money that they would spend on sort of law enforcement goes into treatment and make treatment much more accessible. So it's very easy to get treatment in Portugal. It's still a problem to deal illegal drugs, but drug use itself is not a problem. And then some resources I want to point out here. So if you want to know what can we do, the county actually has good information, and the link here will take you to the county's website in terms of marijuana use. National Institute on Drug Abuse has the latest information on marijuana is here. It's still a little bit more out of date than I'd like to see. So I really appreciate your participation. I see we've got one question from Dr. Joyner already, and it's an excellent question. What services are available for marijuana use disorder treatment for adolescents? Pretty limited. The agencies like Corner Health, Ozone have, for minimal levels of use, might have brief interventions. I think for once the problem becomes more serious, the only formal program in the county I'm aware of is through Michigan Addiction Treatment Services does have an adolescent program, but you actually have to go outside of the county to find treatment that's dedicated for adolescents. Harbor Oaks, for example. So it's really quite limited. If you do have somebody who has a use disorder, they're probably gonna have to travel. I think the biggest thing is trying to get families involved in therapy is probably your best bet. And I'll let our moderators let me know if there's any other questions.
Thank you so much for that fabulous presentation. As Dr. Hopper mentioned, please, if you have any questions, feel free to add them to either the Q&A or the chat. We do have another question, and it is from Andrea, and this was at about 12:28. Just wondering if you can share the identifying information for the article, if you can share that again, and I believe that is referencing your 31st slide, if you're able to go back. But I did want to mention that we are going to have all of the recordings as well as the PowerPoint slides on our website, and I'll include that link in the chat too. So we'll be adding that, and then we'll email all of the attendees when that is live on our website too.
Yeah. Okay. Yeah, I'll look back at that in a second and see if I can identify what that is. For the next question I see in the Q&A now, any thoughts on peer programs? So if there are peer programs in the county, I'm not aware. I believe Corner Health has done some work with this. And in terms of their efficacy, I have, again, not a lot of knowledge. It is known through prevention programs that teach skills around refusal when it comes to substance use are helpful, and that peer involvement in those programs are helpful. So targeted programs, so for at-risk youth, that involve skills training around not using, have been shown to be helpful. Yeah. While we're waiting for, I'll see if I can pull up my the 31st slide here. Oh yeah, so this is slide 31. Yeah, so this is the adverse health effects one, Norvolkow. It's the New England Journal, June 2014. I do believe that they made this a publicly available article, so you don't need a subscription or any kind of special code to get in. It's an important enough article that they made it publicly available. If you have any problem getting it, just send me an email and I can get you a copy.
Great. And we do have another question from Andrea. What have participants' experience been with UMATs at U of M or through CMH Access for adolescent treatment?
Mm-hmm. Yeah, it's, I haven't referred anyone, I would say, in the like post-pandemic. So I think that would be, if there is someone, I don't know if I'm not sure if anybody can see this question or respond to it, or I guess they would probably have to type something. So yes, I don't know what people's experiences are, and I would be interested to hear that.
Thank you.
Okay.
Any other questions? I definitely have a question too.
Okay, good.
But okay, well, I will ask it while we wait for any other people. And you spoke a lot about the negative impacts of marijuana, and I was wondering, are you able to speak to the other physical impacts of like saying smoke inhalation and pop core lungs with vaping?
Yeah, right. When it comes to negative impact, I really was focusing here on brain development. Obviously, there are many different delivery systems for marijuana. There's ingestion, there's inhalation, there's different inhalation methods, there's different even processing. So, some of the products are made through a distillation process that might involve solvents. So I really didn't address anything specific to sort of method of delivery because it does vary widely. There are some things that have been shown to be harmful, and those, fortunately were identified quickly and stopped. So there were some vaping inhalation injuries that occurred in association with a vitamin E was added to vape materials and caused some severe lung injury. But certainly anecdotally, there have been some lung injuries that were probably related to some type of vaped cannabis. And, this is one of the problems with delivery systems, is that they vary, and they can even, the quality control may not be very precise at any one place, so they might vary the amount of some substance that's used in the distillation process. I think when it comes to inhalation or vaping, I guess the bottom line is there really isn't, when it comes to FDA products, there's nothing that's smoked that's FDA approved that I'm aware of. There are some things that are inhaled, but those are not psychoactive drugs, and there's no real vaping or burning has anything to do with medicine, I would say. There certainly are drugs that are inhaled that are medicine, but when it comes to cannabis, a lot of these other systems, there really isn't any process where we would call medicine vaporization of a substance. So it's a long answer to saying we don't know enough, and there are going to be a lot of different varying reports.
Thank you so much. Yeah. Great. Well, we do have a few more minutes if anybody would like to add another question to either the chat or the Q&A. And while we wait, I just wanted to mention too that I'm adding a few things into the chat. One is let's see, our main medical marijuana webpage that Dr. Hopper so graciously added in the talk as a resource. And then another is that our Cannabis in Practice webinar series continues this week and next. And the next webinar is entitled Cannabis for Chronic Pain, a Practical Approach. And it's by Kevin Benke. I apologize for mispronouncing the name. PhD tomorrow on Friday, August 5th at noon Eastern Time. And so if you'd like to register for that, the link is there. And let's see, we have an evaluation link for today's webinar too, that I'm also adding if you would be so kind as to complete that. And it looks like we do have another question too. And this is from Miriam, it sounds like treating the underlying condition is an optimal option for adolescent use. Is this correct? I would like to continue discussion and thank you for the presentation. And I'll pass along her email.
Yeah, thanks, Miriam. I wrote down your email, so I'll reach out to you. Yeah, I think for the majority of substance use in adolescence comes from life out of balance, and then a lot of that does have to do with adolescent uncertainty, as well as clinical disorders, as well as a lot of trauma. So interpersonal trauma, family trauma, social trauma. So that ultimately addressing trauma, addressing depression, mental health. Yeah, I think there'd be very few people that would want to expose themselves to alcohol, tobacco, cannabis, if they felt really good about their lives and how things were going. It's sort of an interesting thing that, like animal models are a little hard to develop for alcohol use, as an example. Animals don't necessarily, other than primates, other animals don't really like the feeling of alcohol. And it's hard to get rats to drink alcohol in a lab model. And from a primate standpoint, the calories are higher in fermented fruits, so that probably led to some genetic advantage for liking alcohol. But beyond that, if you think about how alcohol makes you feel, it really doesn't make you feel all that great. It does have some kind of a social context. Likewise, when people first use nicotine, most of the time they get quite sick off of it. So same thing for opioids. And cannabis as well, a lot of it has to do with social context. So yeah, I think creating healthier lives and a better mental health environment would actually have a big impact on cannabis use for adults and kids.